Today I'm going to be talking about knowing your antibody status. So something that's very important, often the first step when we see patients with myasthenia gravis is testing for antibodies. Before we begin, I do have to at least go through disclosures. I have no relevant financial disclosures. Even though when we're talking about many treatments, I'm not advocating for any specific treatment as well. So at least as far as today's talk, my hope is that after you leave here today, you have a better understanding of antibodies, their role in neuromuscular transmission. So I also want to talk about the clinical presentation. Some of these things will overlap. Dr. Walsh just talked a little bit earlier today, and I'll also talk about, once again, the treatments that relate to antibody status as well. Many of you know this, but just a brief overview on myasthenia gravis, chronic autoimmune disorder of the neuromuscular junction. It's usually characterized by fatigable and fluctuating weakness involving many different muscle groups, the eyes, mouth, speech, breathing, the limbs. It's caused by antibodies that affect the neuromuscular junction. In terms of the prevalence, it's around 150 to 300 per million, and annual incidence of a little bit more than 10 per million. There's many ways we classify myasthenia gravis, at least autoimmune myasthenia gravis. There are other myasthenic syndromes as well, but for the most part, autoimmune myasthenia gravis, which will be really what I'm talking about today, can be characterized by age, it can be characterized by antibody status, by thymus pathology, it can be also characterized by which muscle groups are affected. Certainly other myasthenic disorders have overlapped with autoimmune myasthenia gravis. Those disorders being like Lambert-Eaton myasthenic syndrome, which also can be autoimmune, can be paraneoplastic and associated with cancers, but other things can also be associated with myasthenia gravis, like immune checkpoint inhibitors can cause myasthenic syndrome that's very similar to myasthenia gravis and congenital myasthenic syndromes. As far as the normal function, I just want to talk about this briefly before we dive into the antibodies, especially their roles, not only in the pathophysiology, but how we treat myasthenia gravis. So the nerve terminal, which is the end of the nerve ending, is where a neurotransmitter molecule called acetylcholine is housed. This is ultimately released into a cleft or a junction. So if you hear me refer to either one of those, it's the same thing. It's that gap in between the nerve terminal and the muscle. And that muscle end plate or the muscle membrane is where the receptors that are affected in myasthenia gravis are housed. As far as the antibodies, there are several antibodies that have been discovered to be associated with myasthenia gravis. The first was the acetylcholine receptor antibody. It was first discovered in the 1970s. It was several things, at least, that led to its discovery. We found that animals that were immunized with patients' blood, or at least patients' antibodies, developed myasthenic syndrome, or these symptoms like myasthenia gravis. We also saw that patients with myasthenia gravis had a reduction in the acetylcholine receptor on pathology. And also patients responded to certain treatments, particularly apheresis or plasma exchange. The other two antibodies, at least that we know have pathogenicity when it comes to myasthenia gravis, were discovered in the last 20 to 25 years. The MuSK antibody, or muscle-specific kinase antibody, was discovered in 2001, and the low-density lipoprotein receptor-related protein 4, or LRP4, was discovered around 12 to 13 years ago. Each of these antibodies binds to a membrane protein, as we talked about in the prior slide. I want to talk about acetylcholine receptor antibodies first, as those are the most common. Those were the first discovered. And so to go back to our picture, it has several different mechanisms of action, or at least pathogenicity when it comes to what happens at the molecular level at the membrane. Primarily, it leads to destruction. The antibodies lead to destruction of those receptors. They tend to be internalized into the cell. They're no longer functional. And also can lead to blocking the interaction between those acetylcholine molecules in the cleft or the junction, preventing for them to be bound, thus leading to someone developing weakness. Also, too, there is a triggering of what's called the complement cascade. This is important to at least know about or be familiar with. because some of the newer treatments target this directly. But this is a cascade that's involved in all of our immune systems that ultimately is multiple steps, but leads to the destruction of a foreign object, oftentimes an infection, if you have any type of infection. But in myasthenia gravis, these acetylcholine receptor antibodies will trigger this complement cascade, which thus leads to the destruction of those receptors on the membrane. So as far as the acetylcholine receptor antibodies, as I mentioned, it's the most common one found. It is present in about 80% of patients that have generalized myasthenia gravis, meaning that it's more than just ocular, more than just the eyes are involved. In patients that just have purely ocular symptoms, around half of those patients have these antibodies. These antibodies belong to a specific subclass of immunoglobulin. Those are antibodies. Those are in our blood, the IgG1 and IgG3. The importance of these have to do with, which I'll talk about later, the treatments, the newer treatments for myasthenia gravis, and our understanding of how those treatments target these specific antibodies. There are other subtypes. There's multiple subtypes of the actual antibody. When we actually do this test, when we take the blood test and send it off, there's several different subtypes that are often reported. The binding is the most important, the most prominent one. It's often present in nearly everyone that has acetylcholine receptor antibody myasthenia gravis, but also blocking and modulating antibodies also can be reported as well too. Modulating can be important because it does increase the specificity of detecting myasthenia gravis, especially if the binding antibody is present. The picture is a patient that has generalized myasthenia gravis, has multiple areas of the face and also the neck with weakness. There's drooping of the eyelids. There's inability to raise the eyebrows. There's something called a transverse smile, where there's weakness of the mouth muscles, and a smile looks like a snarl, as some people do describe it. And in the second picture, he's holding his chin up and clearly has a neck extensive weakness, can't lift his head up, so he has to use his hand. Furthermore, regarding the acetylcholine receptor antibodies, the higher the level of the antibody in the blood, the more likely somebody has myasthenia gravis. It's more so at the lower levels or the lower titers, where it can sometimes be consistent with myasthenia gravis, but that's when we tend to see more false positives. The actual antibody titer itself is not really correlate with someone's disease, at least in general, when we look at the entire population. It's more so the actual loss of those receptors in someone that has myasthenia gravis that really leads to the symptoms of myasthenia gravis. But in an individual, depending on their actual level, it can sometimes be associated with symptom severity. What I'll tell you is that oftentimes we don't follow this. It's not really clinically relevant to someone when it comes to how they do with treatment and just over time with their disease itself. And as I mentioned, very low levels tend to be associated more often with what we call false positives. I want to move on and talk about muscle-specific kinase antibodies, MuSK antibodies. As I mentioned before, these were the second antibodies that were discovered to be directly pathogenic in myasthenia gravis. In that box is kind of where, at least representative of the MuSK receptors at the membrane site. And so ultimately what this leads to is when these antibodies target this membrane protein on the membrane, it leads to reduction of the density of the acetylcholine receptors, or an inability to cross-link together. So it prevents the receptors from doing that. Smaller percentage as compared to acetylcholine receptor antibodies. When we talk about MuSK antibodies, it's about 5 to 8%. Some clinical studies say up to 10% of MG patients overall. Patients that are negative, meaning they don't have acetylcholine receptor antibodies, about 40% of those patients will have the MuSK antibody. And this antibody belongs to the IgG4 class. And this is important because it does not activate complement, that cascade I was talking about earlier, which has to do with our immune system, its ability to fight, in this case, in myasthenia gravis, targeting the receptors. It's a different subclass than the acetylcholine receptor antibody subclasses. There are patients out there in the literature that have both actually acetylcholine receptor and MuSK antibodies. This is exceptionally rare. As far as the clinical characteristics, there's a phenotype that's slightly different from patients that have acetylcholine receptor antibody myasthenia gravis. Oftentimes, patients with MuSK myasthenia tend to have predominant bulbar features, meaning They have weakness of the mouth muscles, swallowing, chewing, speaking. Neck muscles often are affected, breathing, and certainly upper arm strength. And one thing in particular that they're found to have too is atrophy of the facial muscles and the tongue. There's something called a triple furrowing that we look for on examination. This is a picture of it. It's not the biggest picture, but you can tell in this patient has difficulty with raising her eyebrows. It's not able to completely bury the eyelashes or close her eyes completely, and has atrophy of the tongue. This is more common in younger patients and women, and particularly Black and African Americans as well. Moving forward, talking about LRP4 antibodies, this, as I mentioned, was the third antibody that was found, or at least discovered, to have a pathogenic association with myasthenia gravis. And so at least it's also has a relation with the MuSK antibody. There's something called agrenin, which binds to it. It ultimately will prevent it from interacting with MuSK, and at least the antibodies will prevent it from interacting with MuSK. So this antibody represents about 15 to 20% of patients with generalized myasthenia that are negative for the other two antibodies. They belong to different subclasses than the MuSK antibody. Some overlap with acetylcholine receptor antibodies in the IgG1 and the IgG2 class, and it's also detected in other neurological conditions. Patients with ALS and MS have been reported to also have these antibodies. So it's not necessarily specific for myasthenia gravis if you were to get this test and it come back and be positive. In that context, it's just dependent on if you're having symptoms consistent with myasthenia gravis and all the other testing that we do when assessing patients with myasthenia gravis. As far as the clinical characteristics, this was taken from an observational multi-center study years ago, looking at patients that had this antibody in their myasthenia gravis. They compared it to patients that were negative for antibodies, and they found that this group tended to have more severe disease, more so in the class of the MGFA classification of 3A and D, meaning that's moderate disease, compared to seronegative patients, at least the group that they looked at, that were more mild. But they do respond to treatment. As far as other antibodies, I'm just going to briefly talk about these. They really don't have much of a clinical role. The striational antibodies, which include multiple antibodies, as you can see, to the ryanodine receptor, actin, myosin, and so on. They can be found in patients with myasthenia gravis. We don't really use this clinically when it comes to assessing a patient with myasthenia gravis. We see it in other conditions too, particularly immune checkpoint inhibitor-related muscle disease or myopathies. It can be associated with malignancy, though, but it's not really specific or sensitive in predicting which malignancy or neurologic phenotype. We just know that it can be present, especially if someone has a malignancy like myeloma. There are other antibodies that have also been discovered. These are a list of them. I'm not going to go into detail. There's really kind of the actual pathogenicity, specificity for myasthenia gravis, and their diagnostic prognostic value remains unclear. So I just want to briefly talk about thymoma-associated myasthenia gravis. It's attributed, at least myasthenia gravis is attributed to thymoma at about 10% of all MG cases, and around 30% of patients with thymoma will develop myasthenia gravis, but 15% will have the antibodies and not have any symptoms if they have a thymoma. So it's not really associated with other antibodies besides the acetylcholine receptor antibody, the most common antibody found in patients with myasthenia gravis. So I'm referring to the MuSK antibody and the LRP4 antibody. And that kind of goes along with, there just hasn't been any clinical evidence to suggest that removing the thymus gland in these patients benefits them long term. So if you see a physician, a neurologist, and they're doing an evaluation for myasthenia gravis, what happens when you get an antibody test and it's negative? Well, several things should be considered. One is that sometimes, especially early on, the antibody is not present. And so that's why I always recommend getting it checked within the next year to see if something called seroconversion takes place, where the antibody is initially not there and then later on is present. About 15% of patients in clinical studies have been found to have an antibody this way on repeat antibody testing. The type of assay, the actual type of test that's done is important. These days, really the majority of labs do what's called the immunoassay, radioimmunoprecipitation assay. There, in the last several years, there have been studies looking at cell-based assays. I'm not going to get into the nitty-gritty of these types of assays, but what I'll tell you is that there is some data that certainly suggests that these cell-based assays, which are not currently available, have actually improved the ability to detect these antibodies, even in small amounts. So the hope is in the near future that we get at least some standardization when it comes to these assays, these types of tests, to make it more easy to detect these antibodies that perhaps we're not able to test with our current testing at this time. Also, too, is the possibility that we just have not discovered all the antibodies that have been associated with myasthenia gravis. And so that's something that certainly time will tell if we find out more. So if you have a test done, it is negative. Oftentimes, the next steps in evaluation include electrodiagnostic testing, particularly repetitive nerve stimulation and single fiber EMG. Approximately 10% of patients with myasthenia gravis will not have those antibodies, as I mentioned before. But I think one thing that clinical studies have shown is that some patients actually have some complement deposits at their motor end plates, and so while we know that plays an important role in acetylcholine receptor mediated or associated myasthenia gravis, what kind of significance that means, time will tell. But ultimately, like I mentioned, the next steps will be these two techniques. And it's important to get these done at a specialized center because what I'll tell you is that they're very challenging and they can be fraught with error and misinterpretation. And I've certainly seen that myself, unfortunately. As far as antibody just testing take-home points, so like I mentioned, it's often the first test that's done is these antibody tests. A negative test does not completely rule out myasthenia gravis, but also a positive test does not necessarily mean you always have myasthenia gravis. And like I mentioned, the lower the titer, the lower the level of the antibody, the more likely that that's going to be a false positive. We can see that in patients that have thyroid disease, rheumatologic disorders, and also other autoimmune disorders as well. So let's jump into the treatment of myasthenia gravis. I'm going to talk about, and some of these have already been touched on, so bear with me here. And some of the older treatments first. I'm going to jump into the newer treatments as well. So really, when it comes to treatment, the most important thing is individualizing the treatment to the patient that I'm seeing. And when it comes to assessing the different things that we look at, these are them, right? How old is the patient? Certainly their gender. If they're of childbearing age, that's important to know because some of these medications you don't want to prescribe because they have teratogenicity. And so other things we certainly consider is the rate of symptom progression, if there's respiratory, meaning breathing or bulbar involvement of the mouth, the chewing, the swallowing, and the antibody positivity, particularly acetylcholine receptor antibodies and MuSK antibodies. We find that MuSK antibody myasthenia gravis respond very differently to the treatments that we usually start with acetylcholine receptor antibody myasthenia gravis, and some actually get worse with some of those treatments too, which I'll talk about in a moment. Overall, though, there's two main groups of treatments. There's treatments for symptoms, and there's treatments that are immune therapies or immunomodulatory. Those are really two big groups of treatments. And at the end of the day, our goal is to improve function, improve your quality of life the best that we can, and certainly minimize the severity of myasthenia gravis. We want everybody to get to remission, whether that is remission that's pharmacologic, meaning you're on a small amount of medication, or complete stable remission, you're off of treatment altogether. Obviously, long term, we want to minimize any of the adverse effects that come with the treatments, because all of you are aware there's a lot of adverse effects that come with these treatments. And as a physician that takes care of a lot of patients with myasthenia gravis, I realize that these treatments can be very helpful, but they also have side effects, adverse effects that long term, I don't want patients to develop those side effects and those adverse effects. First, we're going to talk about pyridostigmine or acetylcholine esterase inhibitors. This is the symptomatic treatment, right? The mainstay of treatment here in the United States for myasthenia gravis. It's usually used first line in all cases, but particularly can sometimes be used only in purely ocular cases, just depending on how someone responds to pyridostigmine. Not everybody does respond, and that's, I think, a part of the fact that there's variable effect on different muscle groups, at least from what patients have told me. Oftentimes, I find that people tell me that they don't get much of a response in terms of their double vision, but sometimes it can help their drooping of their eyelids, for example. But once again, that's not definitive. Everybody's a little different in terms of how they respond to these medications. Certainly can be used in combination with other immune treatments as well. It does not do anything for the disease itself. It's not change the disease process just like the immune therapies do. It just helps with the symptoms. As far as other types of antibody-associated myasthenia gravis, particularly with MuSK antibody, patients with MuSK can actually get worse with acetylcholinesterase inhibitors like histamine. So we often don't try those because, like I mentioned, those patients don't notice any difference or they get worse. As far as the onset, it usually is pretty quick in onset. People start noticing the difference, at least an improvement within 30 minutes. If it does help, it lasts for several hours, then it's out of your system. There are different formulations. There's the immediate release. There's the timed release. The timed release you usually use in the evening time. It's more erratic in its absorption, so it's not always the best used during the day, but in the evening time, it's often used when patients do wake up early in the morning, especially with prominent symptoms or are awoken by their symptoms. There is a syrup formulation too that sometimes can be used in children. But certainly it has prominent GI side effects that many of you probably are aware about that can certainly be limiting when it comes to taking the medication. If patients don't respond, or say if they do respond, but it's not to where they want to be when it comes to their function and their quality of life, we usually at least consider starting corticosteroids. Obviously, prednisone is the one that everyone is familiar with. And so we consider this as really the first line. Of course, it has many side effects that I'll touch on in a moment. It does modify the disease. Like these other immune treatments, it is disease modifying. And usually people can at least notice some benefit within a couple of weeks of taking it. Oftentimes it started at a low dose and ramped up over the course of weeks. And so, how responsive somebody is oftentimes is dependent on several things. If they're ocular, if they're generalized, how affected are they, how rapidly do they develop the myasthenia gravis, and some folks also need to be on much higher doses initially to get a response. Some people need to be on lower dose. Everybody, once again, is different in how they respond to corticosteroids. Certainly, the long-term side effects need to be closely monitored. These are some of them here. Certainly, if you're to look at prednisone, really any medication for that matter, and see what the side effects are, there's a whole host of many side effects that oftentimes when I start a patient on these medications, we really are vigilant. I work closely with the patient's primary care doctors to make sure that a lot of these things, especially the high blood pressure, blood sugar, monitoring that, making sure if someone doesn't have diabetes or pre-diabetes, it doesn't get into that if we're starting these medications. But also, too, some of these other things. And I know Dr. Wells mentioned, other physicians on the team that patients see as well, ophthalmologists, sometimes endocrinologists, too, in terms of their care. But certainly, we try to do our best if someone has started on these medications to try to reduce the risk of developing these side effects or adverse effects. This means trying to have a well-balanced diet, trying to, as best as you can, be as physical as you can be. Certainly, as I mentioned, be it their eye exam, vitamin, calcium supplementation, and so on. Those are things that at least help reduce the risk of things like osteopenia and osteoporosis. There are other immune therapies. Like I mentioned, these are the older ones that we've been using for decades. Oftentimes, these are enlisted if someone is immediately, presents very severe, they're in the hospital, they're sick, that's how they present. Sometimes we'll think about using these off the bat in addition to steroids, and with the goal of coming off of steroids and having this more long-term, but these are considered steroid-sparing agents. The idea there that you can get to lower doses of steroids or off of steroids altogether and be on one of these other treatments. And these are some examples: azathioprine, mycophenolate, cyclosporin, tacrolimus. I don't have another Trexate, there's some others there too, but really those are the most common ones used, the azathioprine and the mycophenolate mofetil. They do require regular lab monitoring. They do have a delayed onset of action, so if you are starting it, you're not going to notice any difference for weeks. Depending on which one, it can take sometimes up to 3 to 6 months, sometimes often longer. It can even take up to 2 years to start noticing benefit with these medications. So it does take a while to notice any difference compared to symptomatic treatments, paracetamine, and then also corticosteroids, as I mentioned earlier. Certainly, there's significant risk, which we also are vigilant in our monitoring blood work regularly. These medications can suppress your bone marrow, so we watch blood counts closely. Depending on the medication, it can affect your liver. You can increase your risk of skin cancer just a little bit, so I recommend everybody that's on one of these to check in with a dermatologist once a year, do a skin check to make sure that they don't develop any lesions that can be concerning for the malignancy. Acute therapies, these are IVIG, intravenous immunoglobulin, and plasma exchange apheresis plex. These are medications that are used oftentimes when someone is in crisis, meaning they're intubated in the hospital, very sick, or getting worse all of a sudden. They can sometimes be used in bridging therapies, meaning that if there's, for some reason, they can't take steroids, sometimes we'll use this as a way to help someone benefit in the short term if we start a medication like azathioprine, mycophenolate, and so on. Some patients have to use these for maintenance treatment, and what I'll say is oftentimes we use this, especially if there's contraindications to use some of those other medications, the corticosteroids, the steroid-sparing agents as well. But usually people will notice benefit within weeks of taking these treatments. IVIG is usually given in a loading dose that's first started over the course of several days. Exchange or plasma exchange is given usually at least 5 exchanges every other day in the acute setting. Some people can get exchanges regularly. They do it every 2, 3, 4 weeks. They can do it, and just that would just usually be one exchange. What I'll tell you is that not many places are able to do that without a central line, meaning a line that goes into one of the large vessels in the neck. Very few places are able to do that peripherally in the veins. So that's something that certainly a lot of our patients live from afar away. It's very challenging to do routinely. All right. So let's jump into some of the newer treatments and some of the new biologics, the new molecular therapies. So approximately about 10 to 15% of patients are considered refractory. They don't respond very well to these other treatments. Like I mentioned, everybody responds differently to these treatments. And the exciting thing about these newer treatments is that they are more selective in the way they act. The goal there is to achieve clinical benefit, but also limit or avoid those side effects, those adverse effects that come with those older medications. As far as the first group I'm going to talk about is the complement inhibitors. These are, at least the ones that are FDA approved at the moment, are eculizumab, ravulizumab, and salgado. And so complement inhibitors have a unique at least mechanism of action. As I mentioned before, with acetylcholine receptor antibody myasthenia gravis, this leads to complement activation, right? That complement cascade that leads to damage of those receptors at the membrane, ultimately leading to someone developing weakness. These directly inhibit that cascade. They bind to it, prevent it from occurring, and prevent the destruction that occurs to those receptors. And the first one that came on the market, at least for myasthenia gravis, was eculizumab. Ravulizumab followed later. But ultimately, there were several different clinical trials that showed benefit, at least in the REGAIN clinical trial, which looked at eculizumab. It did not meet its primary outcome, but the open label extension or long-term data did show that it did improve clinical outcomes in patients. And it was sustained over several years of taking the medication. In the Champion MG trial, which looked at ravulizumab, it did show it also improved clinical outcome measures as well. The main difference between these two is how long it lasts in your body. So in eculizumab, you get your loading dose over the course of several weeks, and then you're getting it every other week, every 2 weeks. It is an infusion medication. So you have to go to either an infusion center or a hospital. Sometimes you can get home infusions as well set up. Ravulizumab has a longer half-life. So this, after the loading doses, you get every 8 weeks or every 2 months is usually when you get your infusions. As far as zilucoplan is a more recent complement inhibitor that's been approved by the FDA, and it's unique in that it's subcutaneous. It's not an infusion that you get through an IV, it's subcutaneous, it's an injection you give yourself. So if somebody has bad veins, for example, they might have a lot of vascular disease, it's just hard to get access, this could be a good option. What's also unique about zilucoplan too is the fact that it may have a role to be combined with other types of treatments, other newer treatments of myasthenia gravis, particularly the FcRn inhibitors, which I'm going to talk about next. And that's because it's not affected by those treatments, whereas ravulizumab, eculizumab can be affected by the recycling pathway, which I'm going to talk about in just a moment. But at least in the RAISE clinical trial, it did improve clinical outcome measures by 12 weeks in patients that were on this. Clinical benefit, or at least effect, can be seen within the first week. It is once daily dosage. You give the injection once a day. And it also can be given with IVIG plasma exchange as well if you're also on those therapies for maintenance. So I have to talk about the risks, right? This is important because while there's all this these studies that show that these medications can provide clinical benefit, there's certainly significant risk, especially with the complement inhibitors, and that is the significant increased risk of meningococcal infections, and that can be up to 1 to 2,000 fold increase. As far as cases, there is not many cases that have been published of patients that are developing meningococcal disease with eculizumab in particular. Many of the clinical studies that have looked at particularly myasthenia gravis have not found patients that develop it. Those are more so our earlier studies that have been done in patients with other disorders that this medication is used for, like PNH, paroxysmal nocturnal hemoglobinuria, and atypical hemolytic uremic syndrome. But that risk is still there. And so if you are going to be taking this medication, you have to get the 2 meningococcal vaccines at least 2 weeks prior to starting, and you have to get it regularly as well as you remain on the medication. If you don't get it before 2 weeks of starting the medication, oftentimes antibiotic prophylaxis is started until you get those meningococcal vaccines. What I'll say is that the CDC does recommend people to be on antibiotic prophylaxis while you're on the medication, regardless of getting the vaccines. And what I'll tell you is that there hasn't been any prospective clinical studies, clinical trials, large clinical studies that have looked at the benefit of being on antibiotic prophylaxis, taking an antibiotic every day, to help reduce the risk of you having this infection. Certainly, as you all are aware, there's side effects and downsides of being on antibiotics. So that is often something I bring up with my own patients about the risks of those being on it as well, because you may have to also be on that in addition to getting the meningococcal vaccines regularly. So I find that often to be a downside, obviously, when speaking with patients about that medication. The FcRn inhibitors is the next group I want to talk about. This is, at least the ones that are FDA approved at the moment, are efgartigimod or Vyvgart and resomelagon. And so I'm going to talk about efgartigimod first. It does have a unique mechanism of action, and what I'll tell you is that it's essentially a more selective form of apheresis or plasma exchange. What it does is help reduce the bad antibodies in the system, acetylcholine receptor antibodies. And that's unique because usually what happens is our bodies actually recycle these antibodies. The cells in our bodies take these up, just like you see in this photo. They usually will take that antibody, put it back into the blood, and like I mentioned, recycle it. But these medications target that pathway, prevent that recycling from happening, and shunting them to be destroyed. And so that is a process that at least helps to reduce those antibodies in the blood, and it does so selectively, targeting that specific subclass, the IgG4 subclass of antibody. So that's how it works. Plasma exchange apheresis doesn't have the selectivity. It overall just takes out good antibodies, bad antibodies, complement factors. This is more selective for the bad antibodies or acetylcholine receptor antibodies. And the ADAPT trial was the main randomized clinical trial that looked at this medication, efgartigimod. Patients did have improved clinical outcomes in it as well. As far as the infusions, so it is an infusion, if I haven't mentioned it already, and usually clinical effect can be seen within a week, but you do have to get the treatment weekly for 4 weeks, and you have to wait at least 4 weeks before your next cycle of infusions. Now, what I'll tell you is that the way it was designed, the way it was planned, was that this medication would be kind of like apheresis, that you get your cycle of 4 infusions, and then you wait to see how somebody does. Now, patients in the clinical trial, there were some that benefited much longer than that 4 weeks, so everybody's a little bit different in how they respond to efgartigimod. Some people don't respond altogether, but there's other people that do. Not everybody needs to get it every other month. Oftentimes, you'll see it started like that, and then seeing how patients do, that can sometimes be tapered or weaned over time. I want to talk about resomelagon next, and this is targets the IgG1 subclass. Same kind of mechanism of action, prevents the recycling of those bad antibodies, shunts them to be destroyed. It's a subcutaneous injection. So efgartigimod is a infusion. This is a subcutaneous injection, that you give to yourself. And the MyCarron G was the randomized clinical trial that looked at it, showed the outcomes. Often, as far as the dosing, it's weight-based. You give it once weekly for 6 weeks, and then you have about 64 days from the first injection to the next dose that you can give. So similar to efgartigimod, where there's a period of time in between each cycle of treatment. So I want to talk about anti-CD20 therapies, rituximab in particular. Rituximab has been around for a long time, and it's been used in acetylcholine receptor antibody myasthenia gravis, but it also is very, very helpful that we know for most antibody myasthenia gravis. It does target like I mentioned, anti-CD20. CD20 is a receptor on B cells. Those are a type of white blood cell in the body, and it helps to deplete those cells, so making the antibodies that cause myasthenia gravis. And so this is just a study of many years ago, about 8 years ago, which first showed some benefit in patients, especially with MuSK antibody myasthenia gravis. You can start to see benefits within several months if you get the infusions. They're given in 2 different ways. I usually will recommend the first way, where you get it day 1 and then day 15 at 1,000 milligrams, but you can do the weekly dose for 4 weeks. There's no difference in how you actually get it in that regard, but I think people would prefer getting it 2 infusions rather than 4. And the next round of infusions you would consider about 6 months later. So this is just a big table. I'm not going to go into details. This is kind of an overview of all the medications that we just talked about. The complement inhibitors, the FcRn antagonists, the ones that are approved by the FDA. Rituximab has not been approved by the FDA for use of myasthenia gravis, but we still use it depending on how somebody's doing, whether they have acetylcholine receptor antibody positive myasthenia gravis or MuSK in particular. And what I'll tell you is that oftentimes we try to go to rituximab very soon after a diagnosis of MuSK antibody myasthenia gravis, because patients can get quite a bit of benefit. Patients with MuSK myasthenia gravis don't really respond to pyridostigmine, don't respond. It's kind of hit or miss with prednisone, steroids, and it's also hit or miss with those other immune therapies that are non-steroidal, azathioprine, mycophenolate, and so on. So we'll try to go towards doing rituximab. The other treatment that people do respond well to with MuSK is apheresis or plasma exchange. But that also requires frequent exchanges to occur. So once again, that is, depending on where you live, the access that can be rather challenging, especially if you can't get it peripherally and you have to get it through a central line. And certainly that increases additional risk if you ever have a central line or a port place for use of these medications. On the horizon, many medications are on the horizon, which is a very exciting time to take care of patients with myasthenia gravis and to also kind of look for the future. There's a lot of different options. There's infusions, there's injections, there's different ways that we're targeting the disease. And I think what we're looking at here is this is just an example of all the different types of those treatments that are in clinical trials right now. The clinical trials that are ongoing, many of them are in phase 3, which is by that point, that's when we're looking at how effective these medications are. That's comparing to a placebo or fake medication that patients are blinded to. And so, time will tell what these clinical trials show. But I think it's exciting because we're targeting new ways to treat myasthenia gravis. And we're moving towards personalized medicine, right? Where somebody might not respond as well to some of these older treatments or to even one of the newer treatments. But if we have different ways of targeting myasthenia gravis, and perhaps there's a synergistic effect too, in some cases using these medications, that's exciting because at least it allows us to get patients better quicker, and not have to go through all these other medications that have side effects to get there as well too.